I think that it's very important what we just heard. And I think that we have to really keep thinking about how to build intersections between detection and prevention. And one of the most important that's come up in several places here is in all these countries that are thinking about implementing, screening is tobacco-related diseases, okay? The eligibility criteria is all built around tobacco, okay? So that created the Bayesian circumstance that brings us to this room. And the push to bring integrated lung cancer, emphysema, cardiovascular, which is a big aim of Agile, forward is addressed by many of the speakers with the first consideration being, oh, can we afford to do this? And the reality is that the cost saving coming out of tobacco elimination in the setting of screening and being the teachable moment that has been commented on is profound. And so one of the things I would ask is, we were talking about models yesterday, and in none of the modeling were we talking about the contribution of screening with prevention to mortality reduction as well as the economic benefit. Would it be a good thing for we in Agile to spend more time encouraging people to use their modeling capabilities to look at those types of issues, because at a national policy level, they're so important? Any thoughts? I'm going to go backwards. Oh, okay, you guys can self-assemble.
Sure, I can address the economic question first. And this is one of the big selling points when we're talking to governments. The United Nations Development Program estimates that 1.5% of global GDP is lost every year because of tobacco. Now think about that. In a world where developed countries are thrilled to have a 3% growth rate, they're losing 1.5% from a product that is killing a lot of their citizens. So it's a pretty obvious argument to make to governments. The only problem, of course, is that the savings come a little bit later, and the tax revenue loss is more immediate. So that's the only issue there. In terms of how we can work together, I was talking to somebody last night at dinner, and they mentioned that we don't really need any more research on the harms of tobacco. We know it very well. What we need is your advocacy, because that's what decision makers, they want to hear from you, and they want to hear from youth. And those are the two biggest, the most important demographics to have show up when a city council is considering a law like this.
Christoph?
Let me add Polish data to that. We had still not very comprehensive, rather fragmentary, but important studies on economics of tobacco control, including the cost of both of treatment of those diseases which are smoking attributable, and also the loss that is created by premature mortality of those people. Most of them are smokers who are not providing anything, to the national budget. The global budget of the National Health Fund in Poland is 250 billion Polish zlotych. 60 to 80 billion Polish zlotych is the cost of tobacco in Poland. So I'm still very much wonder why this data don't touch the hearts and minds of Polish parliamentarians. At every committee of the Polish parliamentarian, we are convincing them, to do step forward with that. This is the first. The second, and fortunately, if we have this money in most of cases are spent not for tobacco control or for the public health, for other reasons, rather closing the gap in the governmental budget. That's the problem. So the problem with will, the problem with skills, the problem with lobbying of tobacco industry in Polish parliament. And the problem also, in my view, with the skills of medical doctors. So we have to convince them that our proposal on incorporating smoking cessation into lung cancer screening is valuable, is just laying on the table. This is something what they have to do. That's the obligation.
Okay.
Yes, so if you don't mind, I stand. I talk better when I stand. So the way I see it is that all of the people here are doing excellent work in your own field. You may not have enough bandwidth to do it, but I think you have direct networks to your younger generation, your medical school, where you want to take my set of slides. There are lots of material on the internet on tobacco-free generation. Invite your statistic students, your mathematical modeling professors from your university to come on board so that they are the ones who work with the young ones to derive those prevention economics data. I think that's so exciting because they have the mastery and the domain knowledge, and that's why I think that it goes back to the teamwork that I talk about. I think that will be useful to move the agenda forward for us.
Okay, great. Many of us know Mary Pasquinelli, who is a leader of lung cancer screening implementation in urban settings. In her area, she happens to work in Chicago, and she's done a great job. And one of the things she does is with every person, she works in a predominantly African-American community of older people, which is one of the most vulnerable populations and most recalcitrant to medical interventions. And she goes over the CT scan, not for lung cancer, but for all the findings. And when there's other findings, people want to know about them. And what happens with her is that she thinks that talking about these things encourages these people to come back year after year and to actually do something about these things because they see it's not an abstract thing, it's them, okay? So this idea that it's a teachable moment and that we could potentially have people with cardiovascular disease or pulmonary disease reconsider smoking cessation in that setting because they have an actual finding in a number of publications has shown to be very important in encouraging compliance. How can we take advantage of those types of positive interactions in terms of driving forward both screening and tobacco control together?
I go for this one. So that's why I think at the beginning of this conference, I was very pleased to see the entire back of the hall with medical students. And I think they need to sit in this conference to hear both the great work that you are doing in terms of lung cancer screening, as well as in tobacco control, so that they are the ones who reach out to various individuals in the community, and they being future doctors, they will help us champion the cause. I can also envision where if, let's just say, we had enough bandwidth, we had gotten 20 medical students here for the entire conference, the 3 days. Tomorrow, we will have a public symposium whereby the medical students will be presenting the information that they have heard today and invite the media so that the media can interview them. So I think we will get a lot of impact that way because the medical students has a way of delivering the message in a simpler manner because we, being professionals and experts in this field, our language has gotten so complex that very often the press and the media cannot catch. And by getting the young ones to be so deeply internalized in the lung cancer screening details, they are the ones who then can be your advocates, teachable moments in the community. Mobilize the public health department so that they now have a program where these students cycling through their program has a session that shares some of these radiology findings because nothing impacts a person better by seeing the change in their own eyes on the computer screen and what they see and the improvement or the worsening. I think that would help.
Okay.
Thank you.
Okay, thank you very much. Chris?
I'm not a doctor, so a lot of what I've seen in the last 3 days has kind of gone over my head. But the most exciting takeaway for me, and I hope I don't have this wrong, is that there's the ability, or at least the possibility of the ability, to see into the future, to be able to tell someone who smokes, if you don't stop in 20 years and 30 years, this is going to happen to you. That is going to be a game changer in terms of cessation. And I wanted to just mention too that one of the big shifts in my career in tobacco control has been we've stopped blaming the person who smokes and think of them as the victim of the tobacco industry. They're your patients. As a lawyer, I consider them my clients, and we have to get past this idea that they can just quit whenever they want. They've been addicted intentionally by an industry that has spent 100 years chemically altering their products to make them as addictive as possible. But anyway, that's the most exciting thing for me, is being able to tell them. It's one thing to tell someone you have stage 4 lung cancer, you should stop smoking. It's not going to save them at that point. But if you can tell them 30 years in advance, you're probably going to have it.
So Chris, I would just add real quickly. They've been smoking for 30 years. They stop, they don't stop, whatever. Screening can help that they do not die prematurely with ever more gentle interventions. Surgically, we just heard about the cardiovascular impact. If people realize that they have bad calcifications and start statins or whatever, it's not a death sentence. They're asymptomatic, and there's a problem, and that can be intercepted before it becomes a death sentence. And they can change their natural. We've got to get the empowerment aspect. Stigma is when people are beaten and they have no control. We want to give back control, choice, and positive outcomes.
Yep. This is another big change, I think, in the paradigm. For decades, governments and advocates have only cared about kids. And for some reason, when they turn either 18 or 21, depending on where you are, we don't care about them anymore. And that just doesn't make any sense. And in terms of the stigma, I've been educated by Dr. Carolyn Dressler never to call them smokers. These are people who smoke. And I realize it's not a big difference, but to them, it doesn't label them entirely by just the fact that they smoke.
Well, respect. Sharing information is respect, and that's antithetical to stigma. Christoph?
Let me talk about it in practical terms. On the one side, we have some handicaps in hands. I'm very happy, I'm even excited that there is such a network as Agile, in which for mutual procedure, mutual goal are working, specialists in different medical fields. Yeah. Okay, so we are talking here not only on lung cancer screening, but also cardiovascular screening, respiratory screening. There is a new group in which I'm also a member, which is lastly very hard working, on incorporating smoking cessation into the work. This is a group of mostly American, but also Italian, Polish, and French urologists. So they also understand the role of smoking cessation for the effectiveness of the work in medical terms. But what we need, first, I see still a big gap between direct collaboration between clinicians and those who are helping people in smoking cessation. So there is no direct contact. There are some hospitals, there are some groups in which smoking cessation is placed into the medical procedures in hospitals, okay? That university is one of the examples. My former university, my former institution, National Cancer Center, is another good example. But in most of lung cancer or cancer hospitals, such a collaboration doesn't exist. Second is open-minded attitude of National Health Fund on that opportunity, okay? I very much wonder, nowadays I'm going back, to the cost that we have also in Poland, okay? The cost of smoking attributable diseases, including lung cancer. why National Health Fund even don't think about payment in some way, for instance, reimbursement of smoking cessation ads, at least for lung cancer patients in Poland and other countries. This is the issue that we have to debate on very strongly, and of course, the arguments are on the table. We have to do much more, you know, to convince politicians and to convince those who have the money in hand.
Yes, yes. So, and I think I'd want to build on another comment that was made, that you made. The example in Milan of using cysteine, a repurposed drug that was looked at freshly for a more intensive and protracted cessation administration, which was associated with, at least preliminarily, a doubling of cessation success. Mario, I think you're involved with that project. The idea that you can take an inexpensive drug and use it much more liberally and really encourage it was remarkable. I think we need to build on that because it's pushing us in the right direction. And these examples of success, I think, builds momentum. So we only have 2 minutes left. So I hear that we need, in Agile, we need deeper integration of relationships between tobacco elimination professionals and the rest of the team. So I think, and we need more communications about some of the positive experiences we're having to bring these. The ministers of health are not going to see better bang for buck, ROI, whatever they want to call it, than many of the things we've talked about today. They're asked to spend money on proton beam facilities and CAR-T, capabilities, and they're wonderful and they're important that we should do them, but they're not going to have anywhere near the economic impact of what we're talking about. And if they're serious about economics being the challenge here, we have to get better modeling data to really dissect this. The CISNET did an evaluation of the number of people that were cured, that were free of lung cancer because of smoking cessation over the final 25 years of the last century in the United States. It's over 1 million people. But no one knows it because they didn't get something, so you can't, it's not palpable. We've got to get better communications about such opportunities. Final comments. It's going to have to be quick.
In terms of funding, the beauty is when we work within the university. The medical students, we don't have to pay them very much. You don't even have to, they can create content, beautiful content that can go out on the internet and social media. And when they organize an event to talk about lung cancer screening, tobacco control, you can invite other schools to come on board. And the fact that you have many, many young people at an auditorium of 1,000, 2,000, the politicians will come on board. They will want to be present, they will be happy to do the opening, and they will say, we support what you do. So again, now that's the answer to the political flipping around, because in the past, tobacco control, if it's antagonistic, punitive, they lose votes. But now the fact that you have 3,000, 5,000 students coming together, they will want to be participating, and that's exactly the experience in Philippines. Thank you.
Okay, final comment?
I'll be very quick. In case an organization wants to get more involved in this, I mentioned during my presentation that we have these steering committees to lend their brains to us about policy. We're starting something on the other side of that, on the treatment and cessation part of that, called the Global Tobacco Endgame Council. If anyone is interested in talking to me about that, please come to me. We already have a bunch of cancer centers that have joined on, a few pharmaceutical companies. So we're very excited about this because it's as important as stopping kids from smoking is helping the 1.1 billion adults who are already addicted to nicotine.
Oh, great, thank you. Final comment?
There are a lot of things in my mind about it, but for a while, I was trying to convince you about the role of the medicine smoking cessation ad that is very popular and in fact, was discovered here in Central and Eastern Europe. Nowadays, more and more recognized, in the rest of the world, including United States. Very soon, it will be registered by FDA. I mean, about cytidine, which is very cheap, very effective, very safe, and very promising. And there are at least a few pharmaceutical companies that would like, to strengthen that process and support us in smoking cessation by this medicine. So there is another chance, to incorporate smoking cessation in quite easy way into medical practice based on that idea.
Okay, thank you. Fred, burning?
Yeah, just to bring everything round in circle. It's important for the tobacco control community, the tobacco prevention community, understand that the tobacco industry is actively working to denigrate the effectiveness of lung cancer screening. My current research shows that about 10% of the articles critical of lung cancer screening have detectable tobacco industry conflicted articles. So, for example, the concept of lung cancer overdiagnosis is a manufactured product of Special Project Number 1 from the Council for Tobacco Research, and we'll try to publish some of that information in the next 6 months.
Thank you, Fred. We'll conclude here. I want to thank all the speakers and the audience for their attention. Great session. Thank you.